Hey, good morning, everyone. I'm really delighted to welcome you to our webinar and launch of the ADViSE programme and commissioning guidance this morning. So a very warm welcome to all of you who've booked out an hour in your very busy days on a lovely spring morning to join us. Nice to have you all here. I'm Medina Johnson. I'm Chief Executive of IRISi, and I'm delighted this morning to be joined by a team of wonderful panelists and speakers. Can we have the next slide, please, Cheryl? So if people would just like to turn their cameras on when I introduce them, and we'll just go through the running order this morning. So Lucy Downs is our social franchise manager and leader at IRISi, and her role in ADViSE has been very much and very importantly in the background doing a lot of modelling work, looking at what ratios we need when we're promoting the ADViSE programme in order to put costings and patient to worker ratios together, which you'll hear more about shortly. And this morning, Lucy's going to be managing the timings, keeping us all in running order, and she'll also be managing the questions at the end of our webinar. Thanks, Lucy. Welcome. Also, very warm welcome to Dr. Jeremy Horwood, Associate Professor at University of Bristol, and also ARC West. And he'll be talking us through the pilot programme that we did for ADViSE and the evaluation. Welcome, Jeremy. We're also joined by Dr. Judith Berry from Unity Sexual Health Clinic in Bristol. Bristol was one of the two pilot sites for the original ADViSE work a few years ago now, and has been an absolute amazing stalwart advocate to keep this work going in her sexual health clinic, and she'll be talking through how this looks in practice, the benefits that it has for both clinicians and patients. So welcome, Judy. Lovely to have you with us this morning. So you can see our running order there. We have a hashtag, hashtag ADViSE. So if you are a tweeter, please do tweet widely. We've already had some good conversations going on already on Twitter, so please do use our hashtag ADViSE. If you have any comments, please put them in the chat. If you have any questions, we will have a question session towards the end of this morning's webinar. Please put the questions in the Q&A. As I said a moment ago, Lucy will manage all the questions for us, and questions will be put to the panellists after we've had all the presentations. We'll leave a good 10-15 minutes for those to take place. So without further ado, I'm really delighted to welcome Nicole, who very kindly has joined us this morning to make some opening comments and remarks. I don't think she needs very much of an introduction to many of you here, but for those of you who aren't familiar with Nicole, Nicole is our Domestic Abuse Commissioner for England and Wales. There's so much brilliant and exciting work going on in our sector at the moment, and a lot of it being led through Nicole and her office and her team. One of the wonderful things with Nicole is that she comes from a service delivery and a frontline background, so she really understands the need for investment and support for frontline services to work in partnership with colleagues like those from health who join us today. So I'm sure she'll comment on that when she speaks in a moment, but welcome, Nicole. Really great to have you here, and over to you.
Right, thank you so much, Medina. That's such a kind introduction, and I know you only have an hour, and so I don't want to take up huge amounts of your time, but I did want to just to come and say how important I think this webinar is, and the work of IRISi in general. You know, domestic abuse is one of those issues that really needs a coordinated community response. And what I mean by that is a huge amount of work to make sure that, as Medina said, we have really robust, solidly funded specialist domestic abuse services, and for that matter, services in relation to sexual violence, stalking and harassment, a lot of the related, very interrelated issues that come up in services that are needed. And we simply don't have that yet. We're very much working towards it. And for those of you who may not be familiar with some of the legislative work that's going on, we have a domestic abuse bill that's just reached the end of its stay at the stage in the House of Lords, and we headed back to the Commons for the last few amendments to be debated. And one of the things that the bill does is that's probably most relevant is that it creates a statutory guidance that will very much feature health and all the various aspects of health, which is what I think is so important, that IRISi plays such a leading role in helping to define what good looks like, whether that's in community-based health services or in partnership with others. You know, I most recently worked with Medina on a project called Pathfinder, which was about really modeling and scaling up our ambitions for what we mean when we say the health response to domestic abuse. So what about mental health trusts, acute hospital trusts, the whole range of community-based services? And we have a long way to go. But I think the statutory guidance that will sit alongside the bill, a lot of the definition in the bill, having a much more focused response to domestic abuse from this point forward will really help us and help these partnerships grow and thrive. And the work that IRISi is doing is a huge contributor, because the approach taken is so careful in terms of evaluation and understanding practice. So it's a real pleasure, and I have absolutely no reservations in really wanting to endorse the work that you'll be talking about this morning. One of the things that the bill does for my office is it establishes for the first time the Office of the Domestic Abuse Commissioner. So similar to the Children's Commissioner or Victims Commissioner, it gives a statutory underpinning for my office and two important powers that I think are relevant in health. So one is about the ability to seek information from public bodies, and also an ability to make recommendations to public bodies that will be responded to within 56 days. And I think there's a lot that we can do and think about in terms of how to use those powers to best effect to really make sure that we progress with these various health responses that are so critically important, because we know, and I'm sure you're about to hear, the evidence about how many times health will be a very early intervention point. We can see a much more diverse group of survivors in health settings, and we can really offer advice and support and identify domestic abuse so much earlier. So there's such hope for these interventions, and a lot of us in the background sometimes feel quite frustrated that these are such obvious things that we need to do and support, and yet we're not seeing the rollout and the expansion of these really successful interventions nearly as much as we should. And I do particularly hope to play a part in helping that happen and helping some of this progress happen a little bit faster. So I just wanted to say thank you for everything that you're doing, Medina and team, you know, the people who've been involved in these practices in action, as it says here on the slide, but also all of you who've come today and who are interested in really playing your part. A very open invitation to get in touch with my office. I'd be very interested to hear your thoughts in terms of the kinds of things that we could be doing. We have a policy team and a research evaluation team, a practice and partnerships team now in place in the Domestic Abuse Commissioner's office. And so there's lots of people other than me that you can reach out to. And we're certainly focusing a good bit of our policy attention now on health. So I hope you'll really see the fruits of that investment on our end. And also you'll have some really good connections in our office going forward. So thank you, Medina, for allowing me to say a few words. Have a wonderful rest of your hour, and definitely please be in touch. Thank you so much.
Thank you very much, Nicole. I know you're not able to stay for the whole event, but we really appreciate you taking time this morning. And you know, having worked with you in the past, that all of what you say I know is utterly genuine, and you know how accessible you and your team are. And I was delighted to be introduced the other day to one of your team, Sophie, who I believe is leading the policy work around health. So we'll make sure that we link in with her and continue to link in with you.
That's right. Thank you so much, Medina.
Great. Okay, so I'm just going to spend a few moments before we look at the actual depth of the implementation and what it looks like in practice and action, just setting the context a little bit for what the intervention actually is. Could we have the next slide, please? So for those of you who don't know about us at IRISi, we are a social enterprise. We are still quite a young social enterprise. We started 4 years ago, born from a randomised controlled trial called IRIS that has been running since 2007. So we have a long history of working in health and with the specialist third sector around violence against women and girls. And here are our vision and mission statements. So we're absolutely committed to working to have gender-based violence in its widest sense recognised consistently and addressed as a health issue. And in order to do that, we see our mission as supporting health and specialist services to work together, partnership and evidence-based work, very much reflecting what Nicole just said. Next slide, please. I know this won't be news for many of you at our webinar this morning, but I do think it's worth remembering the vital response that the health sector offers for patients affected by domestic abuse. So in its widest sense, we know that domestic abuse is a violation of human rights. It's a challenge for the whole of society, and none of us can have failed to have been touched, concerned, and probably angered and upset by recent events. The tragic murder of Sarah Everard, the events that followed, and the sad reality that 2 to 3 women a week are killed through domestic violence and abuse. So it's a society-wide challenge that we all have a responsibility and a part to play in addressing. We know that there's evidence for effectiveness of health and specialist services working together. And we also know that the health impacts of domestic abuse are far and wide, and we'll look at that in just a moment. Perhaps most importantly of all, we know that women affected by domestic violence and abuse expect their healthcare professionals to understand, recognise, ask and know what to do if a disclosure is forthcoming. Next slide, please. And here are some of the very real and wide-reaching health impacts spanning the physical, mental health, emotional health, and also the health of everybody in a family where there is domestic violence and abuse. So in its widest sense, whatever health means or looks like for us, we know that health is impacted by people affected by violence and abuse. Next slide, please. So again, just to really remind us and keep survivors at the centre of our webinar today and all the work that we do, we know that survivors want to feel comfortable and supported to disclose and to be asked directly about any concerns that healthcare professionals might have about violence and abuse. We have very good evidence that even if someone isn't affected, they don't mind being asked. We're not going to offend our patients. We're not going to upset people and rock the boat. It's more important that we ask. As I said a moment ago, we have a responsibility if we're asking to have a response and know what to do next. So an immediate response for disclosure is what we have at the heart of any intervention that we promote, ADViSE obviously included in that. And we know as well that survivors don't want to have to repeatedly tell their story. They want to see continuity of care. We need to be working to make sure that health systems are integrated, linked, and that record systems are linked as well, so that patients don't have to consistently repeat what is going on for them, because we know that that can be re-traumatizing. Next slide, please. So here is what we have been running now for 10 years as a commissionable service, IRIS in primary care. And the 5 points that you can see there on the slide are what we worked on, borrowed and adapted in order to try the adapted version of IRIS in sexual health settings. So we still go through all those very important steps on that second point. We want clinicians to recognise, ask and risk check, respond to patients, have a simple care pathway for referral, make a record of what the consultation with their patient has thrown up in terms of domestic violence and abuse. We know that this increases identifications. We know that it increases referrals into specialist support, which has far-reaching and positive outcomes across the life course for patients affected. We know it supports our clinical colleagues, professionals working in health, and again, most importantly, we know that it increases the quality of life and improves quality of life, safety, confidence, health for patients affected. So if we now go to the next slide, here is an overview of what ADViSE looks like. So it's to offer that same approach in a sexual health setting to support our colleagues, clinicians in sexual health, to better identify and respond to patients affected by domestic violence and abuse. We offer a simple specialist care pathway to a named specialist working in a third sector independent advice service, specialist support service. We know that this is a need that isn't currently in place in many sexual health services for patients. And as I said right at the beginning of what I was expressing, we know that there is important, those links in partnership work are very important. This response to domestic violence and abuse can't sit only with the third sector or only with health. It rests very much within a partnership approach. So the next 3 slides, if we could just forward on again here, we can see the overview of what the ADViSE model provides. So it's capacity in terms of bodies on the ground, people who can support. It's training for the whole sexual health practice family, not only clinicians, but also ancillary staff, receptionists and support staff. It's health promotion materials, materials for staff, both in terms of training guidance, prompt sheets, useful contact sheets and pathways, and promotion materials for patients, which I know Judy will talk about shortly. We also use a domestic violence and abuse prompt, which is embedded in the patient record system. And this works as both a reminder to clinicians to ask about domestic abuse, and it also serves as a way of recording. And again, you'll hear more about that in other presentations. Next slide, please, Cheryl. In terms of the physical capacity, what does this add to support colleagues on the ground? Well, the 2 key things are there at the top of the slide. First of all, the IRIS clinical lead in the practice, and Judy will talk about this shortly. So this is someone who supports training delivery to colleagues in sexual health clinics, champions and waves the flag for the importance of recognising and addressing and responding to domestic abuse. And it's also someone who colleagues can speak with, check things out with, ask if they have any questions, concerns, and also debrief if they've had a conversation with a patient affected by domestic abuse and they just want to check out their response and possibly what next steps are. And then finally from me, the second key person involved, thanks Cheryl, pop back to that last slide again, is the advocate educator. And this is really where the main resource for ADViSE sits. So this is a specialist domestic abuse advocate educator who sits within a local specialist service, who delivers the training with the clinical lead, offers support to staff and feedback on patient referrals, and most importantly is the named contact who receives those patient referrals. So clinicians are able to say, Jane is our advocate educator, I'm concerned by what you're telling me, let me refer onto you with your permission, and she will contact you and she can have a chat and a conversation with you about what's going on for you around the abuse. That then leaves the healthcare professional able to focus on their expertise, the health aspects of the patient, and the domestic abuse advocate, the advocate educator, focusing on supporting around those issues of what's going on for the patient. And we know that, as I said before, this partnership really is effective in best supporting professionals and patients. So I'm going to pass over to Jeremy now to talk about the intervention itself, the evaluation and the next steps. Thanks, Jeremy.
Thanks, Medina. So I was involved in the evaluation, but there was a large team involved, and we conducted it with a collaboration with colleagues from Queen Mary University, ARC North Thames, Unity Sexual Health in Bristol, and Barts in London. Next slide, please. So what did we do in terms of the evaluation? So we piloted ADViSE in 2 sexual health clinics, one in London, one in Bristol, and we used the mixed methods designed to evaluate it. So in terms of the quantitative part, we looked at the patient's records. So this is where we can look at how many times people were being asked about domestic violence and how many disclosures were happening. We also interviewed the sexual health clinic staff from across the clinic. So from doctors, from allied health professionals in terms of nurses and health advisors, the receptionists, and also the advocate workers as well. So what did we find? Next slide, please. So in the first site, which was piloted for 7 weeks, there was a 10% inquiry rate. So 2,500 people were asked about domestic violence. And from those, 6% disclosed domestic violence, and 50% of those were then referred to the advocate educator. In site 2, which went on for a bit longer, so that was 12 weeks, there was a 61% inquiry rate. And in this site, there was the electronic prompt in the patient records that Medina was talking about. So it could be that this enhanced being asked about. Oh, can you go back, please? You can go back again, please. Thank you. So yeah, so 61% of these were asked about it, and it could be this electronic prompt encouraged or reminded staff to ask about it. From this 1,700, 7% disclosure rate, and then a 10% referral rate. And during the previous 3 months of both these sites, there were no referrals about to domestic violence services at either site. So this is starting from 0 to these level of referrals.
Jeremy,
Next slide, please.
So sorry to butt in, Jeremy. Your sound is a little bit muffled. I just wonder whether you need to angle your microphone a tiny bit differently. Sorry to interrupt.
Any better?
Yes, thank you.
Okay. Next slide, please. Now at site 2, if we look at what happened in the 12 months after the training, so the advocate educator was only there for the first 3 months of this, but you can see the inquiry rate stayed pretty stable at 56%. There was a 4% disclosure rate, and then over the 12 months, there was 28 referrals. You can see that the inquiry rate was pretty split between males and females. Disclosure was more within females, and the referrals, it's 100% females here because this is the data from NextLink, which is a specialist service. So we don't have referrals in the patient records. We've only got the referrals that NextLink received. So other agencies may have received referrals as well. Next slide, please. So from the interview, we found that the patients found that it was acceptable to be asked about domestic violence. And as this quote from a sexual health nurse demonstrates, staff reported that the majority of patients welcomed being asked about domestic violence and were glad to have the opportunity to disclose. And most patients thought it was positive that they were being asked, even if they didn't need to disclose. Some patients, a minority, were surprised. The patient usually humorously made light of the situation, but people weren't offended about being asked. Next slide, please. Now, ADViSE provide reassurance to both patients and staff. And as this quote from a sexual health consultant demonstrates, a patient being able to meet a named advocate educator was important. Also, though, that they could meet at a sexual health clinic, which was a known and familiar setting, provided reassurance to patients and may have helped some patients accept a referral. For staff, the quick, simple, and direct referral pathway to the advocate educator was important and reassuring, and reassuring to them that the matter was being dealt with. Also was important to staff was that the advocate educator not only helped the patient, but also provided support and feedback to staff. And this feedback loop reinforced the value of the ADViSE program. And it was important that staff felt like they weren't just referring into a black hole. So for staff participating in the training and the delivery of the program raised awareness and focus on domestic violence and improved the ability of clinical staff to detect and manage instances of domestic violence and abuse. Next slide, please. Also, what was important was that sexual health was the first point of contact for a lot of patients. Because reflecting on ADViSE intervention, all participants maintained that the view that routine domestic violence inquiry and partnership working and referral for domestic violence was important and fitted within the remit of sexual health services, and something that sexual health services should be doing. As this quote from an advocate educator demonstrates, some referrals would not have happened if ADViSE wasn't in place, because otherwise healthy patients would not have been in contact with other health services such as a GP. And we know domestic violence often leads to sexual health and gynecological problems, increased sexually transmitted infections, including HIV, and unintended pregnancies. So this means that sexual health staff can play a key role from their patients accessing specialist advocate services. Next slide, please. So what we found from the evaluation was that ADViSE increased the numbers of domestic violence inquiries and disclosures and referrals. It was viewed as important, appropriate, and welcomed by staff. The majority of patients thought it was positive. It increased staff confidence in asking about domestic violence and managing disclosures. The staff valued the clear referral pathway to a domestic violence specialist. What did come up was that annual staff training would be required. Next slide, please. So after the evaluation, we then use this information to refine ADViSE. Next slide, please. So from the evaluation, refinements were made to the training. So more information about how to ask and when to ask in the consultation. More advice on dealing with cases where there may be an immediate risk of harm. And role plays, for example, things like safeguarding and more tricky cases. Also examples of patients' responses to asking these questions and information about the support services that people were referring on to, and more resources for men experiencing domestic violence. Next slide, please. We also held two stakeholder workshops, both in Bristol and in London. So these were the sexual health clinicians, sexual health commissioners, and DVA agency staff. And this is as we were developing the training and the commissioning prospectus to know what information, what content would be important in those documents. Next slide, please. We also held two groups with patients. So one was patients of sexual health clinics, and the other one was people that experienced domestic violence and abuse, to really get their views on what they thought of the intervention and what improvements could be made. Next slide, please. And then we used all this information to develop the training package for ADViSE and also to produce the commissioning guidance. Next slide, please. And here is a copy of the commissioning guidance, which has now also been endorsed by BASH, which is the British Association for Sexual Health and HIV. And I'll put in the chat some more details about the evaluation if you're interested, but I'll now hand over to Judith.
Great, thank you. So I'll tell you a little bit more about our experiences at Pilot Site 2 in Bristol. We were Bristol Sexual Health Services when the pilot started. We're now Unity Sexual Health Services. Next slide, please. We're a large city centre site, and part of our service includes pregnancy advisory services. At the point before we started the pilot, our training on domestic abuse was the standard training that the Trust provided as level 3 safeguarding. We had no routine inquiry about domestic abuse in the sexual health walk-in service, although this was happening in our pregnancy advisory service. Next slide, please. So just to really echo what's been said about the training, we had a multidisciplinary training for 2 hours, which included our doctors, nurses and health advisors, and a separate reception training session. I was involved in delivering the training along with the advocate, educator and a clinical fellow at the time. And the training was really tailored to the sexual health setting, acknowledging that patients were often seeing us as a trusted place with sort of extra levels of confidentiality. And the training sort of highlighted the cases that we're likely to see in clinic. It improved our knowledge about domestic abuse and the association of health presentations. We had case studies presented by people who were dealing face-to-face frontline with people who'd been experiencing domestic abuse. And we undertook some group work, for example, looking at what factors might make it difficult to leave a partner who was an abusive partner. Next slide, please. The second part of that first session was all about how to make the inquiry. And again, the training acknowledged the existing skills that staff have about taking sensitive histories around sexual activity and building on new ways of asking about domestic abuse. It was non-prescriptive in that we're really encouraged to develop our own form of words that suited individual consultation styles and to choose when in the consultation to ask. So the inquiry could be as simple as asking about if everything was okay at home or how was the relationship, to a more direct inquiry about having ever experienced any violence or controlling behaviour. And we had plenty of chance to practice this in small groups and feedback. And then we got going in clinic and we had a further follow-up session where we could sort of reflect on our experiences. Next slide, please. In terms of the promoting inquiry, we did add some boxes to our EPR system. These were mandatory boxes in that you couldn't progress in your consultation until you'd answered them, but it wasn't mandatory to ask about domestic violence. So you could just say no, that you hadn't asked on that occasion. The boxes were there on every attendance, so whether it was a new or follow-up patient, you would have to answer this question. There was then a free text reminder, a reminder for staff to do an immediate risk assessment and to assess the different aspects of abuse and to think about immediate safety and risk to children. Next slide, please. Supporting that, we had care pathways. Again, these were a little summary that the clinician could have. So these were all laminated and were in each clinical room. And they included a reminder about what to say to your patient and how to make that referral, the practicalities, which boiled down to sending an email and making a phone call. We had separate flowcharts that covered both male and female survivors, and also a flowchart for perpetrators with support services. Next slide. So at the same time the pilot started, we had lots of new resources. So the poster on the right was in all the waiting rooms and in the toilets. And you might not be able to see, but it does contain information for male and female patients. And there's also directions for patients who were worried about whether they were worried about their own behaviour or they'd been violent themselves. The small cards on the left were credit card size fold-out leaflets. And again, these were useful because we often found patients may have experienced some abuse in the past, but weren't quite ready to accept a referral, and they were able to give them information. Something else that we sometimes came across was patients who would hesitate when you made an inquiry and then say, no, everything's fine. And I think we all recognise that there were patients who perhaps weren't quite able or ready to make a disclosure, and again, having information for them was useful. We also had some tiny little barcode stickers made up, so which contain a sort of the number of domestic violence helpline that could be very discreet and put on the back of a clinic attendance appointment card. Next slide, please. So just really to reinforce what's already been said about the role of the advocate educator, our advocate was Sarah, and she was there to really support staff who were having to manage disclosures, knowing what to do next, and was able to have a really rapid response to any referrals we made. Usually she'd be contacting patients the next day or the day after, and it was brilliant to be able to say, we can help you to a patient. We're working with a specialist called Sarah. We can arrange for you to catch up with Sarah in clinic if that would help. Sarah was also able to provide us with reassurance our patient had been in contact, and that feedback loop was really, really important, maintaining staff commitment to the project as a member of our team. And I think that can't be stressed enough, that staff will only ask if they feel safe for themselves, that they're going to be able to manage what a patient might say in front of them. Next slide, please. So our experience overall, the training sessions were excellent and really well received. They completely empowered staff, and there was a real sense of staff wanting to make a change and wanting to make a difference to our patients. And a couple of staff came afterwards and said that was the best training they'd ever had in their clinical careers, the most useful training. Just to echo a little bit about patients, we didn't formally assess patients in the pilot, but our experience was, as Jeremy had said, that patients really welcomed being asked. A lot of our patients clocked that this was new and said, I've not been asked this before, is this something that you're doing? And felt that it was excellent. We did have a couple of patients who found the being asked repeatedly difficult, and these were people who'd experienced abuse in the past, and we needed to learn from that to try and make it a continuous conversation rather than a new inquiry each time they came to clinic, and that was about documenting it really carefully. What we did find, as you would expect, if you're aiming to improve safety, is that there will be safeguarding issues, and those involving high-risk cases or those involving children needed quite a lot of additional consultation time and also additional administration time. So it's worth thinking about how that would work in your service, how you would pick that up. Of the 8 referrals that were made to the advocate in the pilot, 2 of those were high-risk cases that went on to a multi-agency risk assessment conference. Next slide, please. So you might be wondering, well, have we sorted now because we were part of this pilot? Well, the pilot had a lasting impact in that we're still asking the question. We've kept all the prompts on the computer system, and we've updated the flowchart as things have changed. Our referral route is now the standard route into other agencies, and our training in domestic violence has reverted to the standard trust safeguarding, and we try and make sure we have updates from local domestic violence agencies. Since the pilot, we now have a new role of a safeguarding nurse. We have 2 nurses that share a full-time role. And this was partly in response to increased safeguarding activity in the clinic, but also as part of our tendered role as Unity Sexual Health. We're lead provider of a sexual health network, and the safeguarding nurse was in response to having to provide safeguarding across a network. Next slide, please. I had a quick look. This follows on from Jeremy's slide showing you the 12-month data. I wanted to see what had happened in last year. And on the face of it, it looks like our inquiry rate has dropped to around about 40%, and that's for all genders. That figure does include, reflects a lot of the change that happened in our service in 2020 with the pandemic, in that we moved to some increased web-based activity where there's no clinician interaction, and also our main point of contact with the service is via phone rather than walk-in. And whilst we do still ask the question over the phone and we do get disclosures, it isn't always safe to ask when we're doing phone work. We had 295 disclosures last year, and 60 of those were male patients. Unfortunately, our way of recording referrals is not easy to extract from the records. It has to be done manually. But I can tell you that there were 69 safeguarding disclosures relating to domestic abuse, at least 69 out of 340 cases that were dealt with by the safeguarding nurses. Next slide, please. So in summary, it was fantastic being part of the pilot, and it certainly had a lasting effect in the clinic, with lots of changes embedded for those of us who were part of that pilot. But there's still so much more to do, and we need to do better. The main thing is that we now lack that invaluable link with the advocate educator. My experience from child protection has been that where staff know each other as individuals from different agencies, those agencies come together as a really effective multi-agency team, and this is what was at play here. If you want your staff to be confident to ask the question and know that they can manage the answers, you need to have that support in place. So in summary, we'd really welcome the opportunity to once again refresh our skills and be supported by ADViSE specialist. And the timing of this is obviously critical with what we're seeing at the moment with domestic abuse. Thank you. I'm going to hand back to Lucy, I think, for questions.
Hi, yes. We've got a few questions already in the Q&A and through the chat. We've got plenty of time for questions though, so if any of the rest of you have things that you'd like to ask to any of the panellists, please do put those in the Q&A now, and we'll do our best to answer them live. If there are questions that we don't have time to answer during the session today, we will respond to you by email after the event over the next few days. So a couple of questions, I think these are definitely for you, Judy. One which I think will have a straightforward answer. Which electronic patient record system is used at Unity?
We use MIL systems.
Thank you. And another question also for you, Judith, about the health advisors at Unity and what role do they play? Is it different or particular to other healthcare professionals in the service?
Okay.
And the person posing that question has gone on to say, interesting to hear about your safeguarding nurse, just wondering about the health advisor role too.
Okay, so health advisor role varies enormously, I think, across different clinics in sexual health. So our health advisors are there to support patients with issues around health promotion, sexual behaviour, to support partner notification, to support patients managing a new diagnosis, support their treatment. And they're used in different ways in different services. So yes, they will be picking up patients possibly and having a expanded discussion maybe about issues such as drug and alcohol abuse, and then signposting patients to support services. Sometimes the health advisors will do some phone work and pick up the initial referrals into the clinic, and then almost do a kind of triage.
Thank you.
And then the safeguarding nurse, do you want me to do that one now?
Yes, most
Yeah,
well.
so the safeguarding nurse role is another talk in itself, really. But what we've discovered since having safeguarding nurses in clinic, the amount of safeguarding discussions that we have has increased, and we've did a presentation on that for BASH. It again, I think, relates to having staff feeling supported to pick up on those little queries and concerns and worries about patients, to ask the right questions, and then to know there's just somebody to support them with what they need to do to assess a safeguarding situation. Prior to our safeguarding nurses, the safeguarding work came largely through myself, and I was supported by our trust safeguarding nurses, but we soon realised that we had sufficient safeguarding within the service to have 2 safeguarding nurses specifically for sexual health. And they also support our partner organisations in making sure that their safeguarding is in line with what happens over the network as Unity as a whole.
Thank you.
Happy to talk to anyone afterwards. There's a lot more we could say.
Thanks, Judith. I've got a question. I think this will probably be for Medina, but potentially for Judith. Are staff given the opportunity to also disclose their exposure to domestic abuse through the IRISi programme in sexual health clinics?
I certainly recall staff that being something that was mentioned at part of the training, as part of the introduction. I think, as often happens when we talk about various subjects in sexual health, that this topic might have resonance for individuals in the room, and that our advocate would be willing to talk to staff as individuals if necessary. Yes, we probably haven't reinforced that enough, thinking about it over time, but it's certainly when we do presentations in the clinic, we normally acknowledge our staff and also our students when we're talking to medical students, other trainees.
Thank you.
Yeah,
is there anything you wanted to add, Medina?
Thanks, Lucy. Yeah, I think I would echo that. I think that's a very clear offer in the training, that if anybody participating in the training is affected by the issues being discussed, that the advocate educator is very happy to have a conversation and, if appropriate, offer support. It's often more comfortable for a staff member to be signposted to another person, usually within the service where the advocate educator works, because of sort of relationship and potential conflicts of interest. But yes, is the short answer. Absolutely, staff are able to disclose and able to receive support.
Thank you. The next question, I think probably this would be for Medina, but potentially also for you, Judith. In the last year, we have seen an increase in complexity, complex needs for domestic abuse referrals. How would IRISi consider this in their approach?
Shall I take that to start with, and then
Yeah.
perhaps if you step in with your experience from patients on the front line? It's a really interesting question, and since the pandemic started, I've been part of some of the national conversations that have been happening. We have a fortnightly call with a range of violence against women and girls services, coordinated by End Violence Against Women and Women's Aid. And for the last year, we've been hearing very much this, that there is an increase in complexity of cases, that while some services, most not, but some services are seeing fewer referrals, the level of complexity from the referrals that they are getting is much greater. There are safeguarding concerns, and there are child safeguarding concerns as well. In terms of our approach and the ADViSE approach, we want the ADViSE advocate educator to be the sort of receiver of any and all referrals, and then it's up to her in negotiation with the patient and agreement with what the patient wants and how she wants to take things forward to determine what next steps are. So we're very much aware of having the patient at the centre of everything, working at her pace and in line with her needs. The advocate educator role is really to manage standard and medium risk referrals. High risk would be referred into the local IRISi service, the high risk service, and this is for various reasons. We don't feel it's appropriate for the advocate educator to try to balance training, consultancy and support for the sexual health clinic and the patients and high risk patients all at the same time. We don't think that offers the best service for the patients. So we need to think in any area where we work, what services are there already? How can any work that we do enhance and support that work? And we're not there to replace or to steamroller. So this would be looked at on a local basis. And we'd look at what the care pathways were and what the referral pathways were that we could support and enhance locally. Judy?
Yeah, and I think I could see that working in terms of our service. It would just be about those high risk complex cases that are very likely to be the ones where there may be, for example, some child safeguarding. It would be in our service as it is now, developing that relationship between the ADViSE or the advocate educator and our safeguarding nurses, and be really clear about who exactly is going to do what and what parts of it and in what order. And I'm sure that that's the relationship that we could, that could develop. I could see that working really well. I mean, what I didn't say about the safeguarding nurses earlier is that they are sexual health nurses who've developed an interest, and they are fantastic, but they are not domestic violence experts in any way. And so those two professionals would need to work closely together.
Thank you. The next question, this is a good one, and be interesting to hear the response on this. Having this new service to support the existing work of general practices where cases regarding sexual health will be directly referred to ADViSE, or would it be the AE who would signpost to ADViSE? So I guess just kind of absorbing this as I read, something about where, how will IRIS ADViSE kind of work with or alongside or integrate with IRIS for general practice where that service already exists?
So shall I take that one to start with? So IRIS per se, Identification and Referral to Improve Safety, is our evidence-based programme within general practice, and ADViSE, as you've been hearing, is the adapted version for sexual health. In one sense, they exist as distinct and separate services, because what we recognise is the need to capacity build around all areas of health. So where we have an IRIS programme working in general practice, that's resourced according to local funding capacity and focuses very much on patients within general practice. It wouldn't be possible for the same advocate educator to offer the same support in sexual health clinics. We would need additional capacity to be built there. And I've also seen some questions about funding, which perhaps we'll come on and look at in a moment, how are we going to fund and support these services. So I think, as I said a moment ago, part of the local arrangements is for each service that runs around domestic violence and abuse to make sure that it is linked in with any other services. So where IRIS exists in general practice, if IRIS ADViSE is then commissioned and supported, there would be an expectation that workers, the resource capacity available to deliver those services would link and support each other and work in a complementary way, as there would be, when IRIS general practice arrives in an area and is hosted by a specialist service. It works very much in tandem with all of the services that exist there already.
Thank you, Medina. That leads on actually very well to one of the other questions that has come in, which is about, as you said, Medina, the issue of funding. Can you address the issue of how you propose this to be funded and sustained, please? Are you seeking national funding? You'll know that local authorities are unlikely to afford to fund additional services without having a direct impact on other domestic abuse services. What solutions can you suggest, please?
Judy, I don't know whether you want to talk to that from a sort of Unity perspective, what you've seen and what resource you have locally, or whether I should start off with that.
Do you want to start with the national questions? Yeah.
Yeah, sure. Yes, I mean, this is the million-dollar question, isn't it? You know, we know that there's a need. We know that clinicians want to be able to better support patients, and we know that patients need better support, but how do we fund it? And I think that's really part of the conversation that we need to hopefully influence and start today. We have challenges across the health. We know that we have challenges across the specialist third sector. We need to be thinking very widely and very broadly about what opportunities there are, and working within the same financial frameworks, perhaps making things go further and thinking more creatively. I know there isn't additional resource within the system. I think it's about looking at things that work, things that we have an evidence base for. We need to be lobbying commissioners, grant holders, funders to invest in services that we know have positive outcomes and work. We've been challenging for some years now the request from funders to develop new, different, additional things, which are very often only funded for perhaps a year. That isn't long enough to demonstrate impact and outcomes, and then the funding moves on to something else. So we appreciate it's a challenge. We are looking for local investments for this. Yes, there is no national funding at the moment around this. But I do think there are opportunities in some of the things that Nicole mentioned at the beginning. We know that there will be a package of support offered around non-legislative parts to do with the domestic abuse bill when that reaches its conclusion and is passed into legislation. We know that there may be opportunities coming through COVID funding. You know, we're not saying that COVID has necessarily increased incidents of domestic violence and abuse, although, you know, in some areas it has, but it has uncovered a lot of what was there already. And so perhaps we need to think about some of the specific pockets of funding levelled around the pandemic and COVID that also might be supportive. I think it's about being creative and realistic at the same time. What we can't do is expect either our health services or our specialist third sector services to put things into place without funding and capacity to do that. They're already both stretched to the absolute limit, so we need to find some way of supporting and funding them.
Thank you. I think we have time perhaps for one more very quick question, if the response to this is going to be quick. It's the question as to whether there were any particular challenges in supporting patients from different ethnicities with regard to getting a disclosure or having a discussion flowing after a sexual violence consultation. Sexual health consultation, and relatedly, whether any cases of FGM were uncovered or as a result of the inquiries that were undertaken in sexual health consultations. So I guess that perhaps is a question for maybe for Jeremy or maybe for Judith, but either way it will need to be quite a relatively brief response.
I can start. No cases specifically of FGM disclosed as a result of these type of inquiries, although increasingly it's something we're tuning into routinely with patients and asking about. And the other question, I think, is really probably just one of time. listening and understanding patients presenting, potentially using interpreters and using language line, managing access to the clinic, and really taking time to understand and hear those disclosures is the main challenge. So that's the main complexity. I think we're placed to hear and listen, but it is usually just a big time challenge in a busy clinic.
Thank you, Judith. Is there anything to add, Jeremy, from the evaluation side on those questions?
I think from the patient record data we had, we didn't have ethnicity. I think we just had gender.
Yeah.
Thank you. Okay, I think we are out of time for questions. So, Medina, I think it's over to you now for closing remarks.
Thanks very much, Lucy, and thank you everybody for the questions that have been submitted. As Lucy said, if we didn't get to your question, we'll certainly commit to providing a response over the next few days. And if any other questions come up after you've had time to think about the event today, please again do send them through to us. So what I'd really just like to encourage you to do, our sort of call for action really is what you can do next. What can you take away from today? What could you be thinking about? So please raise awareness about ADViSE among colleagues, come back to us, ask us questions, think about any opportunities for improving responses to clinical practice, to patients around this, and how we can support with that. And think of opportunities perhaps for sharing materials with your local commissioners, local contacts, influencing at policy and strategy level to try and make and enhance services for professionals and most importantly for patients. Last slide, please. I can see Lizzie has asked a question, will the slides be shared? Yes, we'll make sure that we send out all of the links that have been shared in the chat, as well as all the slides to participants. And also we had a waiting list for the event, so we'll make sure that we send things out far and wide. Thank you very, very much for attending. Thank you to all our panelists. And if I can also express a real heartfelt thank you to two people who've been invisible throughout the event, but please just flash on your videos now. We said we've got a second Medina Johnson. The world doesn't need a second Medina Johnson. I think this is Cheryl Baker behind the Medina Johnson flag, who is our support officer and who's put the event together. So thanks very much, Cheryl, for being there in background and putting everything together. And also a very big thanks to Jayza Darvo, who is our comms manager at IRISi, who's done all the lovely artwork, organised all the Twitter feeds and all the social media for the event. So thank you both very much for working very hard and very quietly in the background. Thank you again for all joining us today. I hope this has provided some food for thought and given you some energy to go away and have conversations locally about IRIS ADViSE. Please do come back to us with any questions. Wishing you all a really good day, and thank you very much for attending our event this morning.